The role of PD-L1 testing in urothelial cancer has been a complicated topic, and the data continue to evolve. In the past, we did not use PD-L1 testing to inform treatment decisions, and then we had preliminary results from IMvigor130 and Keynote-361, which changed the label for first-line treatment of metastatic urothelial cancer with atezolizumab or pembrolizumab to restrict the label to patients with high PD-L1 expressing tumors. Now that both of those studies have read out, we know a lot more about why those decisions were made early on and what this all means. In summary, PD-L1 testing is very specific to the assay that's used, and it's very specific to the context of use. So the first lesson that we've learned is that PD-L1 testing does not mean the same thing with the same assays and across different disease states, and we really need to make these decisions based on the question that was being addressed in a specific study. What we learned from Keynote-361 and IMvigor130, and we saw results from both studies updated at ASCO GU 2021, looking specifically at the labeled indications for these drugs right now in the frontline cisplatin ineligible setting. We saw the subset analysis for patients in IMvigor130 of single agent atezolizumab versus standard of care chemotherapy in cisplatin ineligible patients with high PD-L1 expressing tumors. And in that analysis, though exploratory based on the hierarchical statistical analysis plan, in that analysis, we saw that atezolizumab was associated with a improvement in survival compared to standard carboplatin-based chemotherapy with a hazard ratio of 0.5. Again, this is an exploratory analysis, but certainly is supportive of the current label for frontline treatment of patients with atezolizumab who are cisplatin ineligible. We saw data from Keynote-361 as well, doing a similar analysis and not reaching the same conclusion. And I think one thing we can say about this is that these biomarkers are different. We know that in IMvigor130, the proportion of patients with PD-L1, quote unquote, high tumors based on the SP142 antibody clone and the assay that's used along with the atezolizumab, the proportion of patients was 24%, and it was over 50% in Keynote-361 using the 22C3 antibody clone and using the CPS scoring system. So we're comparing apples and oranges here. I think the top line is that the results with atezolizumab and pembrolizumab in these randomized phase 3 trials in cisplatin ineligible patients really mimics what we already knew about these drugs from the single arm phase 2 experience, that these drugs are associated with response proportions in between 20 and 30% of patients, but when those responses occur, they tend to be of prolonged duration. Whether or not we can use PD-L1 testing to identify the patients who are most likely to achieve those responses remains somewhat of an open question, but certainly the data do support using the SP142 assay with atezolizumab in this context.